I'm Dr. Jeffrey Vakil. I actually work here at Chestnut Hill Hospital. I'm with Premier Orthopaedics, just to tell you about our practice here. We're independent practice, but fortunately work well together with Temple and have an office here in the medical office building at Chestnut Hill Hospital. We provide orthopedic care for multiple subspecialties. We see back pain, neck pain. Our surgeons really are board certified in sports, hand, joint replacement, but we do deal with a variety of multiple conditions, orthopedic conditions, and you just need to call our office and we'd be happy to see you. But I personally am a joint replacement surgeon. I am fellowship trained. I actually had my training, my medical school training at Jefferson Medical College. And then I went to residency at Drexel and did my joint replacement fellowship 15 years ago at Johns Hopkins University. So I specialize in hip and knee replacement. And that's what I brought here to Chestnut Hill Hospital. And so we're going to talk about hip and knee arthritis and your treatment options. Next. All right, so osteoarthritis is the most common form of degenerative joint disease. Simply stated, it is the wearing of the cartilage at the ends of the bone. It affects 27 million people, adults in the US alone. And some of the most, hip and knee replacements are some of the most frequently performed and effective surgeries worldwide. And the main indication for hip and knee replacement or joint replacement surgery is osteoarthritis, which unfortunately reduces function and quality of life. Approximately 800,000 knee replacements are done per year in the US, and those are the most recent numbers. And I have some of these numbers here. Graphically, we are ever increasing the number of hip and knee replacements. Knees seem to be more so than hips. But by 2040, we are going to be potentially, and actually, I think that numbers, I think this curve, particularly for primary knee replacement, is actually going to be 1 million, probably 1 million knee replacements a year, probably in maybe the next 5 years. But unfortunately, arthritis itself, and I'm going to explain a little bit more about the arthritis. We'll go through the anatomy, but basically it costs a lot of money in lost wages and medical care. People have to take time off. They have a lot of pain from their arthritis, and these studies have shown that it definitely can cause restricted work activity days, and it really account for a lot of time off from work because of knee arthritis. Alone in 2017, 750,000 knee replacements performed. And by 2030, probably, again, close to 1 million. And then also, if the original knee replacement wears out, that's called revision surgery. We will actually re-replace the worn out total knee replacement. They typically last 15 to 20 years, 9 out of 10 times. So let's talk about the anatomy. What the anatomy is, what can go wrong, what you can do about it. So say you have a painful knee. Well, certainly there are muscles, tendons, bones, ligament, and cartilage. Particularly looking at the knee, there's a lot of complex structures around the knee when you take off the skin surface. And there's muscles in the thigh that really help move the knee. And certainly the tendons and ligaments help hold it together and make it a stable knee joint that bends and extends. It's a hinge joint. So really the bones that make up the knee are really comprised of the femur bone or thigh bone, the kneecap, also called the patella, and then the shin bone called the tibia. And then there's a small bone on the outside called the fibula, which only contributes as a structure that a ligament attaches to the fibula. It really, when we talk about knee arthritis, it really doesn't involve the fibula itself. There are ligamentous structures on the inside and outside that give the actual knee stability, along with the medial and lateral menisci, which are also cartilage, which is also a type of cartilage. But really the main cartilage that we're going to really be talking about when we talk about arthritis is articular cartilage. That is the cartilage that is adherent directly to the ends of the bone and to end of the femur bone and top of the tibia bone and underneath the kneecap. And it's similar to that cartilage you see at the end of a chicken leg, where it looks white and cushiony and smooth. So early on in life, the cartilage is thick, cushiony, and smooth. But unfortunately, over time, that cartilage can wear away. And that wearing away of cartilage is really what we call arthritis, osteoarthritis, or degenerative joint disease. Now, there is also a condition called rheumatoid arthritis or inflammatory arthritis, which is a group. Inflammatory arthritis or arthritis are a group of diseases that involves the degeneration of the joint, but it's because of our own bodies actually starting to break down our joints. But really, we're going to be talking about the treatment of arthritis. Now, a lot of inflammatory arthritis like rheumatoid, psoriatic arthritis, and osteoarthritis, all really in the first couple stages can be treated with the conservative measures I'm going to mention. But typically in the setting of an inflammatory arthritis, we will have the help of a rheumatologist to help us with treatment options. But if you have knee pain, what do you do? What's wrong? How do I find out? Well, certainly we would start out by, you'd start out by making an appointment with myself as a specialist for hip or knee pain. Particularly, we're talking about the knee today, and then we'll talk about the hip in a little bit. But basically, you come for an evaluation, whether it's your primary or a specialist like myself. And first things first, we get a history. Find out how long this pain has been ongoing. And knee arthritis can actually come up suddenly. Knee arthritis, unfortunately, is an insidious disease. Your knees and hips start to deteriorate over time, and any joint for that matter that can become arthritic, it's an insidious disease that can occur over time. And oftentimes we will have mild arthritis, and then it'll start to progress. And then we'll perform some activity, getting out of a chair, going on a long walk, running, jogging, some sort of twist. I bent over and my knee started to hurt. Well, certainly we get all that history and figure out what exactly was the inciting incident that resulted in the knee pain. And then we do a physical examination, critical I love to get my hands on joints, kind of poke around things, move them all around. I like to really get my hands on joints, and that really helps. Physical examination really helps support the history and really helps us determine what is going on, because there are other conditions that can cause knee pain. And sometimes hip arthritis can actually radiate to the knee, where patients have more knee pain than hip pain. But these are all filtered out through physical examination. Certainly tests. X-rays are critical. Standing X-rays of knees, and we get a couple of different views, are critical in the evaluation that I would be performing for determination of whether a knee is arthritic or not. Occasionally we'll get an MRI. That's certainly not the first line. I do give lectures to the medical doctors, residents, and students about the utility of MRI in diagnosing knee arthritis. I'll tell you that above the age of 50, if we had obtained MRIs of asymptomatic patients, about 50 to 60% of them will have findings of arthritis. So arthritis is quite common. And in fact, X-rays, simple X-rays, are really all we need to really make the determination of osteoarthritic changes, or any arthritis for that matter. So let's get back to what arthritis is. So I have a picture down here. Oh, let me see if I can go back here. Sorry. A picture here of an X-ray of a normal knee. This is the one on the left. And when we get an X-ray, we like to get standing films. And if we see space in between the ends of the bone, that actually represents cartilage. Like I said, arthritis is the wearing away of this cartilage. And so ultimately the ends of the cartilage wears out. And when it gets down through that cartilage layer, it gets down to bone. So when we look at X-rays, if the bone is touching the bone, all of the cartilage has worn, and that's what we refer to as bone-on-bone arthritis. So here again is a picture of no arthritis, and here's a picture of severe arthritis. You can see the significant difference in between the two. So it's wearing of the cartilage. This causes inflammation and pain and limitations of activities. So wearing of the cartilage is true in both hip and knee arthritis. So here's a couple x-rays of bad arthritic changes. These are the standing views I like to get. These are standing views here. And then we get a bent knee view. And that really helps us look at multiple different locations of the knee. Then there's a side view we like to get, which is called a lateral. And then I like to look at the underside of the kneecap to see how much cartilage there is underneath the kneecap. So these are really the 4 views that I like to get. And I love to get both knees on the standing views, because that really helps to compare the two. And we can see that this unfortunate person has pretty significant arthritis on both sides, and it's bone on bone. Why do I get arthritis? Well, it's multifactorial. There's not one thing that we can point to that really is the reason why we get arthritis. It can be just genetic, wearing of the cartilage. Unfortunately, extra weight on the body can definitely cause more degeneration by putting pressure on these joints. Injury, and really time. As we get older, unfortunately, our bodies just don't last as long, and things do wear out as time goes on. So what are the treatment options? Well, we start out with most conservative options, and there's 2 types of over-the-counter medications we talk about: anti-inflammatories and Tylenol. Anti-inflammatories really consist of Motrin, ibuprofen, Aleve, Advil, and those are really in the breadbasket called non-steroidal anti-inflammatories. However, we have to be cautious about these anti-inflammatories because they can cause kidney issues, they can cause bleeding, can cause stomach issues such as ulcers. But that is really when anti-inflammatories are taken in the long term. I typically recommend a short course of anti-inflammatories. However, consistency of use of anti-inflammatories really helps the most, helping to decrease that inflammation over time. And I typically give like a 4-week course of anti-inflammatories and then have you stop the anti-inflammatory to give your stomach and kidneys a break. Tylenol, and we also have, again, there's over-the-counter prescription and also prescription brand anti-inflammatories. Tylenol can be taken. There's a couple different strengths of Tylenol, and Tylenol is actually pretty safe medication. Certainly, we don't want to take too much Tylenol, and I typically define how much Tylenol should be taken, because certainly overtaking Tylenol can adversely affect the liver. And if you like to drink alcohol, Tylenol and alcohol don't go well together. So then we start out, and then we then progress, and we talk about rest and activity modification. Hey doc, I like to run and jog. Man, my knee's killing me. We get an x-ray, it shows arthritis. I'll tell them, you know what? It's probably not a good idea to run and jog. I think low impact activities in any setting of arthritis are really what's recommended. And then, so certainly rest, activity modification, low impact exercises like biking, swimming, walking, treadmill, elliptical, all of these are nice low impact activities that really help. I would tend to tell people to stay away from running and jogging. Physical therapy is essential. People always look at me funny when I say physical therapy. Why would I do physical therapy if you just told me I have osteoarthritis or degenerative changes of my joint? Well, therapy, whenever there's any pain around any joint, the muscles around those joints become weak. By strengthening those particular muscles, it helps to stabilize the joint. It's not going to do anything to the underlying arthritis because, unfortunately, arthritis is a chronic degenerative condition that continues to worsen over time. There's no reversing it. There's no stopping it. It will continue to worsen. There are supplements that they're on TV. I won't need joint replacement ever. I'll be honest, those supplements. And there's a particular ad that I hear on sports radio about using your own cells. You'll never need joint replacement. Unfortunately, stem cells and platelet-rich plasma, if you've heard of those types of injections, do not reverse the course of arthritis. But certainly low impact exercise and physical therapy, at least from strengthening your muscles, are really good for you. Weight loss, key. Gotta lose weight. Always very important to focus on weight loss and staying in good shape. Then we can also get more aggressive by bracing, using a cane or walker if it's really bad, and joint injections. What type of joint injections? Well, there's cortisone and there's joint lubricants. Cortisone is a powerful anti-inflammatory that we inject into joints that helps reduce inflammation, help with pain. Those can be given every 3 months. Typically, I use Kenalog, but it is a steroid that's injected directly into an arthritic joint. And again, takes about 5 to 7 days to work. And you can get them safely every 3 months, and they actually work very well. As the arthritis worsens, the effectiveness of these injections may not be as promising, but again, these are definitely good options of management. Joint lubricants called Synvisc, Orthovisc, Uflexa. There's multiplicity of these different medications. They're made in a laboratory. They simulate joint fluid. Again, they are marketed that they'll grow cartilage back, they'll fill in the spaces, pad the ends of the bone. In fact, when they look at the mechanism of action, they don't know exactly how it works, but in some cases, really more mild to moderate arthritis, they may act as an anti-inflammatory in some fashion. And again, they don't really know exactly how it works, but can be beneficial in certain patients with arthritis. As the arthritis worsens, they may not work as well. So you just have to understand that as arthritis worsens, we're going to have limited options. And one particular Synvisc is actually from chicken combs. The rest are really made in a laboratory. All right. So what's next after all of these conservative options? Well, certainly you talk to a joint replacement surgeon, whether you've had all of these treatment options by myself or a non-operative physician, or you've had treatment by me. Ultimately, if none of these options work, then we talk surgery. And what is that surgery? Partial knee replacement or total knee replacement? Now, I'm going to focus on knee replacement here, and then we'll talk about partial knee replacement. So total knee replacement first, then partial knee replacement, and then we'll get into hip arthritis and hip replacement. So, knee replacement has come a long way. We used to, not me, but prior to my career here 15 years ago, that started 15 years ago, the old school orthopedic surgeons used to make huge incisions on the front of the knee. We found that we really don't need those huge incisions, so we make smaller incisions. And when we talk about minimally invasive joint replacement, we're really talking about smaller incisions. Now, people also talk about, well, do you cut into the tendon? Do you not cut into the tendon? Well, these are the three ways to get into the knee joint: cutting into the tendon, into the muscle, in two different places, and then underneath the muscle. Any of these approaches into the knee joint have not made any difference. When they tell you we don't cut into the tendon, that is really a marketing scheme that is really not proven to be any better than any of these other ways to get into the joint. So cutting into the tendon is equally as effective as putting in a knee replacement, with equal outcomes in any of these cases where they say we don't cut into the tendon. What they don't tell you is they cut into the muscle. I personally don't like to cut into any muscle. I think tendons heal better, but again, that is my opinion. And again, none of these have really been shown to be more effective than the other. Knee replacements all over the world, whether it's done by this surgeon, this practice, that practice, this country, that country, really all do about the same. Thousands of joint replacements are performed constantly, every day. And really, we're seeking the true minimally invasive procedure, because the smaller incisions we make, the faster people will heal. So I concentrate on making the smallest incision possible, so we can put in the implants appropriately. And we do have happier patients when we do the smaller incisions, because they heal faster. Now, talking about surgical options. Now, when we talk about arthroscopy, because oftentimes people will come in with a knee MRI and they'll say, hey, listen, I have a meniscal tear. Why don't we do knee arthroscopy? And that's actually sticking a scope inside the knee and cleaning up some tears of the other cartilage called meniscal cartilage. In the setting of arthritis, with the wearing of the cartilage, meniscus will tear. The meniscus will tear. And every time I do a knee replacement, the meniscus is always torn. So when people come in with their MRIs that say, hey, it's arthritis, but look, I have meniscal tears, can you scope my knee? It's not recommended. Really, arthroscopy is really for the younger patient population who has an acute injury from an acute sports injury, or the occasional older patient who has no arthritis and has a meniscal tear. But anybody with arthritis who has a knee arthroscopy will not really have any long-term benefits. So then in early to mid-stage arthritis, then that's arthritis in one part of the knee joint, not in all three, like I've shown you in a couple of the pictures before. we can consider a partial knee replacement. Now, partial knee replacements really consist of about 5% of the population. Most people have arthritis in multiple different areas. There's 3 really different areas. There's the inside, the outside, and the front of the knee. If you have it at least in 2 areas of the knee, total knee replacement is the right option, not partial knee replacement. But partial knee replacement, again, 5% of the population, it's replacing one part of the arthritic joint. It's similar to knee replacement where we replace the arthritic bone, we remove the arthritic bone and replace it with metal and plastic. The recovery time, no question about it, is shorter because it's just one part of the knee and we don't remove any of the stabilizing tendons. And they actually function pretty well. And they are a bridge to a total knee replacement because unfortunately, once you have arthritis in one part of the knee, typically other parts of the knee do wear out. So this is an example of having arthritis in one part of the knee here on the left picture. And again, really only about 5% of patients are really appropriate for this. This is a little blurry picture, but this shows that there's arthritis and the outside of the knee also. And if the arthritis is bad enough, performing a partial knee replacement, it may not be the right thing for you. So that's really the discussion between you and your orthopedic surgeon. So that's unicompartmental knee replacement. So again, the recovery is faster, typically outpatient or 1-day stay in the hospital. People really like it. There's no increased complications, and patients are really satisfied with this procedure. But again, the other parts of the knee can wear out. And they're through very small incisions. So unfortunately, people do have, most of the time, 95% of the time, have arthritis in more than one area of the knee. Here's a person with bad knee arthritis on one side and then a really normal knee on the other. And you can see both in the outside and inside is really virtually bone on bone. But total knee replacement is really the gold standard of treating advanced knee arthritis that has failed conservative measures. 90% of them last 15 to 20 years. So that's a really good amount of time, and it's one of the most successful procedures in orthopedic surgery. I will tell you that knee replacements are very challenging. I will definitely have a long talk with my patients about knee replacements and really tell you that, listen, knee replacement is something that it really requires the patient to participate in. And ultimately, it takes a lot of work on the patient's part, because once we put in a knee replacement, it requires the patient to get into physical therapy and move the knee. If you don't move the knee in physical therapy afterwards, then it's going to get stiff with scar tissue. And a stiff total knee replacement is a patient that's going to be miserable. So this is what a knee replacement looks like. Again, we trim off the ends of the arthritic bone and we replace it with metal implants. We typically cement these onto the bone. Now these can be wedged onto the bone and the bone can grow into them. Now that's a little bit newer implants. And the data is still out on whether these are going to be better than the actual cemented implants. But ultimately, I'm just going to talk about cementing implants onto the bone. But they work very well and they last a long time, 90% of the time. And that's what a total knee replacement looks like with cemented implants. It's a little older version of knee replacement, but that is a knee replacement. And I see there's some questions. I will answer them all at the end. Now let's talk about the hip joint. So the hip joint is made up of the upper portion of the thigh bone called the femur. It angles off into a neck and ends in a ball, and that ball sits in a socket. This is more of a ball and socket joint, so there's cartilage on the end of the ball and cartilage on the inside of the socket, and that cartilage, again, is a padding to allow that ball and socket to move smoothly upon one another. Over time, unfortunately, that cartilage can wear away, and wearing away of cartilage is, again, called arthritis, osteoarthritis, or degenerative joint disease. So in a normal X-ray of a hip, there should be a nice round ball and a space between the ball and the socket. Here you can see this is bone-on-bone arthritis. This patient has let their hip arthritis go so long that the ball, which used to be round, is now flattening. So the 4 signs of arthritis are narrowing of the space, spurs, whitening of the bone, and cysts in the bone. And that's also in knee arthritis as well, but that is really a perfect picture of hip arthritis, bone on bone. This leads to stiffness, loss of motion, loss of strength, deconditioning, muscle atrophy, similar to what we find with knee arthritis as well. And this is a great picture of hip arthritis. And in fact, I'll kind of give you a little bit of background about me. I played college ice hockey and baseball at Franklin and Marshall College, and I actually wore out my hip. and I've done thousands of joint replacements. This is actually my hip 6 years ago. So my normal hip's on the right side, my arthritic hip is on the left side, and in fact, I already have a hip replacement. So not only have I performed thousands of joint replacements, both hip and knee, but I have a hip replacement myself. Well, the treatment options also are similar to knee treatment options. They consist of rest, activity modification, similarly over-the-counter medications like anti-inflammatories and Tylenol, weight loss, physical therapy. You can consider cortisone injections into the knee or into the hip, and that's typically done as an outpatient in either a radiology department or under real-time X-ray or under ultrasound. Knee injections with cortisone and the gel injections can be done in the office, but hip injections, there's a lot of structures that need to be important structures that need to be avoided. So it needs some sort of imaging to get cortisone in there. We do not use gel injections at this juncture for hip arthritis. And then, of course, the use of cane and walker. And then for advanced degenerative arthritis of the hip, then we talk about total joint replacement. And in some cases, I find that hip replacement is easier than knee replacement. I do what's called the anterior hip replacement. These are the implants, and I'm going to talk about anterior hip replacement in a minute. I'll talk about a couple different ways to do hip replacement, but the implants really are a piece that goes into the socket. These are made of titanium. There's a titanium stem, there's a ceramic ball, there's a titanium socket piece that goes into the socket, and then there's a plastic piece that separates the titanium socket from, and we use actually ceramic balls now, but separates the ball from that metal socket. So this is actually my hip replacement. This is what I look like. I did not actually do my own hip replacement, but I had one of my former partners do it, and they did a nice job. But conventional joint replacement surgery used to be painful. We used to make huge incisions, just like knee replacement, and it would result in long rehab, significant blood loss, but it was a successful procedure. We've come a very long way. Hip implants have gone through many generations and transitions. We used to make long incisions, but we found we don't have to. We can make tiny little incisions now. And this was started in the early 2000s, where we started to investigate smaller incisions. And again, with smaller mini hip incisions, we really have really gone through excellent transition into these mini hip incisions, and people actually heal very well from these. And again, people do very well from hip replacements. So there's a couple different surgical approaches. There's posterior, where the incision is made in the back of the leg, and back of the hip, and basically tendons have to be removed to get to the hip joint, and those tendons are then repaired back to the end of the bone. There's lateral, where a tendon is taken off the side of the hip, and then we can enter the hip through that interval. And then there's a procedure called the direct anterior hip replacement. I'm going to talk about that the most because actually that is actually my specialty. I've probably almost done, maybe at this juncture, 1,800 to 1,900 of them. And again, I have a special view on this because I have one of my own. But anterior hip replacement has really revolutionized my practice because it's a small incision. It's about 3.5 inches or 9 centimeters in length. It's on the front of the thigh, and I basically split between natural muscle planes, and I remove none of the stabilizing muscles and tendons. And I'm going to talk about that in a second. But there are other approaches, there are old approaches that I'm not even going to talk about. So the posterior approach is one that comes from the back of the hip. There's an incision, really. This is the back view of the hip joint itself. And there are these very important tendons that are typically in a posterior approach removed off of the bone. And then we can access the hip through that back. These tendons are repaired afterwards. Unfortunately, you are close to what's called the sciatic nerve. Chances of injury to that sciatic nerve are very limited. But I think the biggest part of actually having a hip replacement from the posterior approach is that once you have those tendons repaired here, they're never quite the same. So afterwards, there's typically a pillow between your legs. You typically cannot bend your leg past 90 degrees or turn it in because there is a risk of dislocation. Because posterior approach surgeons remove those tendons, particular movements of the hip can result in hip dislocation. Sorry. So people can't really bend over, they can't cross their legs over. After a couple months, it's probably safe to do it. And there are two peaks in dislocation where the hip pops out. There's one immediately after the surgery where the tendon is not quite healed. And if you move your hip in an abnormal position, that it can pop out the back and tear those tendons. Then later on in life, then it normalizes to a certain extent. And then as time goes on and we do age, unfortunately, our tissues are not as strong. And basically, that hip can start to dislocate later in life. All right, so that's the downside of posterior hip replacement, is that you have to have limitations with range of motion, and there's a higher dislocation rate. Coming from the side, this is a side view of the hip. There's a big muscle called the abductor muscle that attaches to the side of the hip called the greater trochanter. That's just part of this bone, but we actually take down part of this tendon and we can replace the hip in that fashion, right through that interval between between that muscle where we've taken down that muscle. When we repair it back, unfortunately, it can lead to weakness of that muscle and a limp called a Trendelenburg gait. And if we've operated on the right side, as we see in this picture, it can result in the pelvis tilting down. And that's because that muscle never really gets to be, it never goes back to its normal functional activity. That doesn't happen every time, but that is a higher risk with this type of procedure for having weakness of that muscle and what can result in a chronic limp or what's called a Trendelenburg gait. However, I will tell you that all hip replacements, whether it's posterior, whether it's lateral, whether it's anterior, in the end, after probably about 6 months to a year, all of those replacements all are doing very, very well. So what is the anterior hip replacement and why would anybody want one? Well, anterior means actually operating from the front in a small incision right here. And I basically split between this muscle called the tensor of the fascia lata and the sartorius. There is a natural muscle plane here that once I make an incision through the skin, and again, this is only 9 centimeters in length, I can dissect right between those two muscles, and the hip joint is right there. So I remove none of the stabilizing muscles and tendons. And once we're done with the hip replacement, the muscles just fall back into place and we just close a little bit of fascia overlying that. And then basically we close the skin with glue and a mesh that goes right on the skin. And basically that's all the incisional closure. And it's, again, a tiny little incision. I use a modified OR table to put your hip into funny positions, but it allows me to get the hip into a position where I can put the implants down into the femur bone. I do it under real-time x-ray. So all of the implants are put in as I'm watching them. So I'm putting in the implants, whether it's this socket component or the stem. I put it exactly where I want to put it because I'm watching as I'm putting these implants in under real-time x-ray. And this enables me to put these in accurately, sized appropriately for you, and most importantly, in the end, getting your legs equal in length again. Because hips, we can lengthen limbs, we can shorten them, and sometimes people come out of hip replacement with a longer leg or a shorter leg. This enables me to be very accurate with the placement of implants. Placement of implants are extraordinarily important because of stability. And ultimately, the stability will lead to less dislocations. And again, from the anterior approach, removing none of the stabilizing muscles and tendons, the chance of dislocation is extraordinarily low. And again, removing none of the stabilizing muscles and tendons will decrease the risk of potential limp in the future. So both of these things are very, very small chance of happening, dislocations and limp post-operatively after an anterior approach. And again, it's a tiny little incision, and we can put those implants in very accurately. It's a low dislocation rate. There's no restrictions. You don't have to, you can move your leg in whatever way you want. You can tie your shoes. Typically, people go home the next day after surgery. I've had a few people go home the same day of surgery. Less pain because we're not doing as much to the soft tissues. And you can resume driving faster. You can resume working. You can resume exercise and stair climbing. However, I will tell you that I do put these implants in. I wedge them into the bone, unlike a knee replacement that I typically cement into the bone. I wedge these into the bone, and over an 8-week period, the bone grows into these implants. So we really have to give. You can walk immediately after a total hip replacement, but you really shouldn't twist or hop on your leg until I've verified that your implant has fully grown into your the bone has fully grown into the implant. But resumption of activities really start very quickly after total joint replacement, particularly anterior hip replacement. Typically 1 day stay, and then you go home afterwards. We like to send our patients home, both hip and knee replacement. Home is really better. There's a lot of thoughts, oh, I should go to a rehab facility. Rehabs are great for certain patients. Total joint replacement patients are typically healthy patients that are just passing through to have their joint replacement. And home is really the safest place to be. Lower infection rate, lower chance of bad things happening medically. It's just better place to be at home. And again, postoperatively, no abduction pillow, no precautions, driving when you feel comfortable. This is my hip replacement here. Patients asked to go home, and they really, listen, any joint replacement is going to be tough. I typically see pretty significant improvements in pain from anterior hip replacement in about 2 weeks. Some people do take a full 4 weeks to 6 weeks, but really about 4 to 6 weeks, people are doing really, really well, and they really are appreciative of that minimally invasive procedure. Conclusions. Prevention of arthritis is always better than treatment, but that's hard because it's a chronic degenerative condition. Again, prevention occurs with keeping your body in good shape, keeping up with the strengthening, limiting the high impact activities if you find out you have hip arthritis, and again, staying in good shape. And again, all of those conservative options are things we can try. Joint replacement surgery is becoming more predictable and less invasive, and really is something that is working very well for many, many patients. New technology is clearly part of the answer, and as results improve, patients' anxiety decreases and recovery times are ever improving. All right, and this is a picture I used to use. These are my two daughters. This is when they were younger. They visited me at the hospital, and now they are older. One is a senior, and the other one's a freshman. So this is my family.